Obviously, because of massive ascites, you are eventually the small bowel loops, they will eventually shows polycyclic. It's a lollipop-like arcuate appearance that has been shown during the USG, right? So there is a coarse internal ecose that has been the blood, and the fine internal ecose like the chiles, or in some cases, in case of like let's say there is a TB or there is a pseudomyxoma peritoni, there is a multiple septation also has been noted in some cases. Okay, so the loculated and the atypical fluid distribution has been seen in some complicated cases. Also, there is a matting, clumping of bowel loops, specifically seen in case of pseudomyxoma peritoni or some kind of carcinoma uh, spreading into the peritoneum in that case. Okay, so obviously you guys can have a look, like there is X-ray image that has been given here, and there is a USG image. Both of these are basically pretty much synchronous with the findings of ascites. Obviously, upper G endoscopy and CT MRI is there. Your upper G endoscopy to look for the complication of the underlying disease, and the CT MRI basically gives you some ideas regarding the right perihepatic space and the Morrison's pouch, Douglas pouch, which are the eventually the dependent portion and the collection there. Your malignant ascites also like the shows some fluid in the laser and the greater sac as well in some cases, but your benign ascites typically shows the fluid in the greater sac normally, right? So you guys can easily able to appreciate in this image, like there is a ascites, and that ascites is typically shown in the HRPM, which is the hepatorenal pouch of Morrison, right? So let's try to understand regarding the abdominal paracentesis. Okay, so we usually like to do your abdominal paracentesis in the supine position, and the site is supposed to before going into the procedure, obviously you would like to go for the shifting dullness test and just to get the idea regarding the fluid level. Okay, uh, before going into the technique, always try to understand you do need to go for proper antiseptic cleaning before the procedure. Okay, and then you can obviously insert the needle through your abdominal wall, and uh, you can be pretty much assured by aspiration of the fluid content from the ascitic fluid. Now, obviously, your ascitic fluid analysis is pretty much important while diagnosing the cause. Like there is a total protein, gram strain, total glucose, chloride, cell count, cell type count. These are basically there: amylase, LDH, glucose, and also like the A B smear culture has been also obtained in some cases. Okay, so obviously there is a two image has been given, like the your left sided image has been gives you an idea regarding how it is supposed to be done. We usually take like the wide bore a cannula, or you can use your uh, um, or you can easily use your wide bore IV cannula in some cases to get into the place like the for the paracentesis. And this is the right sided image typically showing umbilicus eversion with a superficial venous prominence, a prominence in that case, and obviously there is a tense ascites you can easily able to appreciate. So your white cell count typically less than 500 leukocytes and less than 250 pmn is basically pretty much significant in such cases. Your RBC more than 50,000 per ml in the ascitic fluid is supposed to be there is a hemorrhagic ascites. Your this uh, gross appearance of the ascitic fluid, like if it is like the translucent or yellow, which is supposed to be the normal findings, but in case of your brown colored appearance, that is typically suggestive of there is underlying hyperbilirubinemia, or sometimes there is a GB perforation in some cases. So cloudy on the turbid one is a suggestive of the infection. There is a pink and bloody tinge which is due to the mild trauma. Sometimes there is a gross blood which is typically either due to acute onset trauma or there is a malignancy. Sometimes the patient may shows milky color ascitic fluid that is supposed to be either due to thoracic duct injury, or there is a lymphoma, or sometimes there is a cirrhosis. Okay. Regarding, obviously, apart from that, there is a total protein gram stain which will eventually gives you an idea regarding the underlying organism that has been involved here. Your cytology is there to help you, and the SAG value, which is basically serum albumin ascitic fluid gradient, right? So this is supposed to be uh, pretty much useful to differentiate between which is either it's a portal or a non-portal one, right? Apart from that, you can also go for the culture of the ascitic fluid and the LDH estimation, triglyceride, amylase, and the bilirubin. Specifically, what I want to say is that amylase, your ascitic fluid amylase level and the lipase level, specifically in the post-operative period, like after a major abdominal surgery, typically suggestive of the pancreatic fistula in that case. So there is another classification that has been given. Okay, so it's basically your spontaneous bacterial peritonitis if the PMN cell count is more than 250 and there is a bacterial culture is positive against it. But if it goes like more than 250 and the bacterial culture is negative, it's a basically culture negative spontaneous bacterial peritonitis. But obviously there is a mono microbial one which is like less than 250 pmn cells are basically available, and the polymicrobial where the less than 250 but the multiple pathologies or the multiple etiological agents has been responsible. Also there is a secondary bacterial peritonitis that is also important you to understand where the PMN value is more than 250, and you might able to encounter more than one or single organism. Now the type of the ascites according to the serum albumin gradient, which is basically high gradient and the low gradient. I'm not going into the details like there is a cirrhosis, hepatitis, cardiac ascites, portal vein thrombosis. These are the high gradient one, and apart from that, rest of the things are the low gradient one. Okay. Now your indication for admission of this patient, obviously for some investigation, patient is not responsive to the regular therapy, your dietary limited to the 88 millimole of sodium per day, monitoring grade 3 ascites, your suspected bacterial peritonitis, patient is coming to you with some electrolyte abnormalities, your hepatorenal syndrome, hepatic encephalopathy, and the refractory ascites. These are the one which is pretty much helpful. Regarding the management, obviously it's a pretty much non-drug management, like your bed rest, medical care, diet, fluid restrictions are there. So in the drugs, we have two main drugs that has been pretty much important to us. One is the diuretics, and another is the beta blocker. So obviously in the diuretics, we can use the spironolactone and we have the furosemide. Okay, so both are typically used. We are usually starting the patient on furosemide mainly, followed by spironolactone or the potassium sparing diuretics in that case. In case of diuretic resistance, your therapeutic paracentesis is supposed to be done. Okay. Also, there is a liver transplant, extracorporeal ultrafiltration with a reperfusion is there, and the tips is pretty much important in case of resistant patient in such cases. Also, apart from that, liver transplantation is there, and the regular follow-up with the proper monitoring and typically prevention of the spontaneous bacterial peritonitis, and for that case we do need to educate the patient in such cases. Okay. Now, regarding the refractory ascites, obviously your fluid load that is not responsive to the restriction of the dietary sodium and maximal dose of the diuretic therapy in absence of the ingestion of the NSAIDs. So here the management is supposed to be serial large volume paracentesis, which is 100 milligram per kg at a time. Also, you can start the patient on the IV albumin 6 to 8 gram per liter. So thank you for today's session. It's been pretty much informative one. If there is any queries, please do let me know. I'm happy to answer your queries.